office manual that we created, and learning opportunities such as this webinar. Since tomorrow is National Rural Health Day, it's an annual opportunity to focus on the unique challenges and opportunities related to healthcare in rural communities. So this webinar is intended to highlight a successful state partnership between the Primary Care and Rural Health Office and then the State Health Officials Office to measurably improve care delivery and outcomes in rural areas. So thanks again to Marcella and Alisa for agreeing to do this.
Yeah, great. Thanks, Megan. Yep, I just wanted to come back with a couple of housekeeping notes. I'd like to remind everyone, obviously, if you're hearing this, you're on the telephone dial-in. We're using that for the audio and not the web platform. So the web platform is only for slides. There's no audio functionality through the web platform. Please also take a moment to go ahead and please mute your lines now. We'll have an opportunity for Q&A at the end, so you can unmute yourself to ask the question at that point. Without further ado, I'd like to introduce our two presenters today who will be discussing how to use rural health clinics to improve chronic condition management. Marcella Bobinsky is the Acting Director for the Division of Public Health Services for the State of New Hampshire. She is also the Bureau Chief of Public Health Systems, Policy and Performance in the Division of Public Health Services. She was the New Hampshire Immunization Section Chief for 7 years. She has worked in the not-for-profit sector for 40 years. Experiences include 6 years as the Campaign Director for the Central Illinois United Way, 9 years as the Director of Marketing, Training, and Planning for the Mental Health Centers of Central Illinois, and Adjunct Faculty Member for the University of Illinois at Springfield. She has served as President and Treasurer of the National Association of Immunization Managers during her 5-year tenure on the Board of Directors. She attended the University of New Hampshire for her undergraduate degree, and she earned her master's in public health from the University of Illinois at Springfield. And Alisa Druzba has been Administrator for Rural Health and for the Rural Health and Primary Care section at the New Hampshire Department of Health and Human Services, Division of Public Health Services, since May 2006. In this capacity, she oversees the State Office of Rural Health, the New Hampshire Primary Care Office, the Medicare Rural Hospital Flexibility Program, State Healthcare Workforce Loaner Payment and J-1 Visa Waiver Programs, and associated staff and contractors. She has a background in information technology, clinical mental health with care of adolescents, family therapy, youth development, and community dynamics. Ms. Druzba has a bachelor's degree in political science from Centenary College of Louisiana and a master's of community and social psychology from the University of Massachusetts. We greatly appreciate both of their time and willingness today to present. In the interest of time, I'll turn it over to them to get underway with their presentation.
Great. I'm going to start. This is Marcella Bobinsky, and thank you very much for giving us this opportunity to speak about our rural health programs. We're very proud of them in this state, and I think we've done a tremendous amount to make sure that the folks in our rural areas have access to health care of many kinds, and actually through the good work of Alisa and her team, that access is expanding into arenas other than primary care, and so that is very exciting. I'm not sure what our next slide is. Oh, okay, the acknowledgments. So I just want to talk a little bit about the leadership role of a state health official, and as you can see here, we have put up essentially a picture of what our New Hampshire State Health Improvement Plan looks like on its cover. And this essentially references the idea that a state health official is foremost the person who can offer vision and leadership to an entire division of public health, department of public health, any kind of entity. And it is that leadership that essentially should be pointing all of the partners, all of our stakeholders, all of the staff within the division in some kind of direction. And so we certainly have, in 2013, we charted the course for about 7 years. And our bureaus and our sections and programs within our Division of Public Health have been working towards reaching the outcome goals that were set in 2013. So it's essentially, how can the leadership, how can the state official set up this framework so that staff, leaders throughout the division have a sense of where they are going. It's not up to the leadership to say, oh, yes, that's a good idea. Oh, of course, that's a good idea. Of course, that's a good idea. It's up to the entire staff to create those ideas, create those relationships and conversation, but they're all headed towards a goal that has been agreed upon, not only with leadership, but our partners and our stakeholders throughout. So one of the, the elements essentially of our state health improvement plan include these areas: tobacco, obesity, diabetes, cardiovascular disease, and on and on. I have set within this, not only was it these, if you will, diseases that we are trying to bend the needle on, bend the curve, but also what's very critical is the surveillance and epidemiology, that we understand the data, that we are able to gather the data on a real-time basis, which of course for us continues to be a challenge, and also the issue of local data, which continues to be a challenge, but that's something we're working on. And of course, essentially what we're trying to do is promote health, protect our communities, and prevent disease. So once we decided essentially on these 10 major factors in the state of New Hampshire, bureau chiefs, section chiefs were able to look around, look at each other, and say, how can we improve the health of New Hampshire citizens regarding these, what we think are critical diseases, if you will, in our state. So this particular program, and Alisa will tell you much more about this, was able to look at the issue of diabetes and look at the risk factors that make up cardiovascular disease and say, how can we work with these and look around and find more partners? And I think that's what we're going to be hearing about in a few minutes. But again, back to what a state health official can do to create, to make sure that these improvement plans are moving forward. It's not only creating some vision and offering up that leadership, but it's been empowering the staff to do what needs to be done. I'm a great believer in the fact that there are so many experts within the field of public health, and that the range is so diverse that I don't believe that one person sitting at the top can have all of that expertise. So how can I empower the people who are really responsible for these programs to lead within their program field and to be that strategist within that program field? So really it's about empowering. And the other big issue, of course, in terms of empowering, how do we make sure that these people are being creative, are looking with their heads up around about them to make sure that they're getting all the stakeholders that they need? It's also about managing up. It's very important for the leadership in as a state health official to manage up, whether it's to a commissioner, whether it's to an executive council, whether it's to a governor, legislators. It's about creating space so that the people who are trying to improve the health of New Hampshire are able to gain the footing that they need. We're able to break down the barriers that they may be meeting up against. So really it's managing up and out in terms of a state health official. What do these folks need? What can I do to make sure that they are getting what they need to do the jobs that they have been empowered to do? And of course, the other major thing that I think all leadership should do is that celebrate, saying thank you. I hope that I get to say thank you, a dozen times a day to the staff throughout this building for something that they have done. And when you empower people to work and you give them goals, say meet these goals, please, create these positive outcomes, it's then up to the state health official or that leader to say thank you And how did you do that? And let's hear the good news. And we try to celebrate that every day. We had a celebration today because our food protection program was able to stand up after many years of work, an information technology, a management tool, and it's important to celebrate. So it's the vision, it's the empowerment, it's the barrier busting, and it's celebration. And I don't know, I'm not going to say I don't know much, I don't know nearly enough about what has happened or what does happen in terms of Alisa's shop, how she goes out and works with all of the different critical access hospitals. But that's her job. That's her world. How can I help her? How can I support her and encourage her? That's my world. So in terms of state health officials working with programs and creating these fabulous projects that actually improve the health of people in our rural communities, what we can do at a leadership level, I think, is to empower and celebrate and give the vision. So again, nothing real specific, but I think it really is offering up that opportunity is the critical portion of what we can do.
Okay.
Yep.
We're going to literally switch chairs so that I can take over. So I just wanted to start with one of the first things we did working together in public health. Even though the state office and the primary care office have, I think, always sat inside public health, I don't know that we really sort of understood each other until a few years ago. And so one of the first things we did was we have regional public health networks, and we work together to classify them as either rural or non-rural, and that's been incredibly helpful moving forward because that way programs that are not used to working in rural can immediately see whether or not they have priority areas based on health disparity data that fall into rural, and then hopefully reach out to me and we can work together on doing some programming and solutions, which is exactly what happened with this project that we're going to highlight today. So the first thing is that we all state offices are pretty small funding-wise and staffing-wise, and I think a lot of primary care offices are also the same. We are the same. I'm the same person, so I'm the state office director and also the primary care office director. So it really makes it easy to coordinate work, which is great, and also to coordinate funding resources. And so what I wanted to do was we wanted to start working with rural health clinics because we recognize that there's no other entity that's specifically funded by the federal government to work with them. So we have critical access hospital programs that work with them, we have the federally qualified health centers, and we have a number of other programs that really nobody was sort of reaching out to rural health clinics. So knowing I had limited expertise and resources, we started out with what I call our baby steps. So just really, reaching out, finding out who they are, finding out who the contacts are, and then offering them some very concrete opportunities like traveling to conferences or updating them on things that might be applicable to them, telling them about the work that we do in case it comes up later. I've sent people to grant writing classes virtually online. We pay their way for that, just, really easy resources like that. And then the other thing we did is we created and actually had approved by both our governor and the Secretary of Health and Human Services for the U.S. a certified rural health clinic designation policy. And so what this does is it enables an alternate format for applying for rural health clinic status. And then we wanted to get sort of bigger into doing TA. So what I did is we worked with the National Organization of State Offices of Rural Health, NOSOR, and I actually engaged their services for a fee, very reasonable fee, and they did a need assessment of all of our rural health clinics so that I could get even a sense of whether or not they wanted TA, what kind of format it would need to take, and then that was the building blocks for us to start moving forward on this idea. And then the next thing we did is I identified some internal partners in public health that might have goals of reaching rural health providers. So I am very familiar with, and I'm sure anyone who works in rural health is very familiar with the disparities of your populations. And so what we needed to do was find the chronic disease program or whatever program was working in public health that may have had a interest either as guided by a funder or by their own data in rural, and we did that. And so we started working with the chronic disease section here in public health, and we decided to combine our funds and craft an RFP together so that my needs could be met and their needs could be met, and most importantly, we could have an impact in a way that we couldn't have alone, and also meet the needs of our funders. So we did that, and we did the RFP, and we had some really, I mean, it wasn't a lot of money to show you that. So about $30,000 from my shop and $80,000 the first year, or the first 2 years, and then now $65,000 going. So really, in the grand scheme of things, not a lot of money. So I was very pleasantly surprised to get a number of very well-crafted proposals from very reputable companies. And so we were delighted, and we ended up scoring and selecting one through a competitive bidding process and moving forward with contracting and the actual creation of the Technical Assistance Network. So this is our contractor, and it's JSI Research and Training, and they have a Community Health Institute. They're a national company, but we're lucky that the Community Health Institute just happens to be located here in Bow, New Hampshire. And then our Institute for Health Policy, which is part of our University of New Hampshire. And then we have a sort of local expert on hypertension management, and that's Dr. Fedrizi, and he does work out of a rural hospital. And so that's the team that they presented as part of their RFP. So this, I'm going to go through, I have a lot of slides, and a lot of them are just going to be references for you for later, but I just wanted to go through and give you just a general overview in case folks are new to the concept of rural health clinics. So this is how many there are and where they are, and you can see some states have a whole bunch, and some states don't really have that many, and there's, I don't think, a particular rhyme or reason for that. It's just sort of what works, which model works in particular in each state for the type of providers and needs of their communities. So these are the rural health clinics in New Hampshire, and all but one of them are hospital-owned, and of the ones that are hospital-owned, a majority of them are owned by critical access hospitals, so that's a 25-bed or less rural hospital, and so they just have a number of different needs and supports, and some of them are part of very formal ACO or other value-based payment modeling or chronic disease management, and some of them are not, and so they have a lot of different things going on. So I think that was probably one of the challenges and why we really needed their feedback, was how do we program for such a diverse group of folks and with so many different needs, or actually really I think asks from other groups besides us as far as being their level of involvement. So this was just sort of a goal and strategy overview, and then these are basically the things that we wanted to do. So it's sort of, if you think about it as a reverse pyramid model, what we wanted to do is we wanted to do a needs assessment for all 14 rural health clinics, and then we would offer technical assistance webinars to all 14 of them based on topics that they had identified. And then we would ask all 14, but not really expect all 14 to collect clinical measures focused on hypertension. And we started with hypertension, and diabetes comes later. But and then we gave them an incentive to do that in the form of a gift card. And then we knew a smaller group then would actually be able to commit to the Action Learning Collaborative, which is focused this first session on hypertension, and then kicking off now with diabetes. So that's how we structured it, knowing that we would be programming to meet the needs of everyone, and then sort of winnowing down who was able to make that full commitment to some of the more intense work. And that's fine, and that's a model that I've used with critical access hospitals for the past 12 years, and it seems to work really well. And so the needs assessment, some of the outcomes, I just wanted to show you the types of things that you can learn about your rural health clinics if you do an intense needs assessment like this. And so we learned that these are some of the kinds of services that they provide, and a lot of them are a little bit beyond the scope of what you would consider traditional primary care, but it's very reflective of what the community needs are and what some of the market influences may be in their area. These are the kind of providers that we found out and the numbers they had, so that was really interesting to find some podiatry in there, and excited to see some psychiatry in there as well, and a little bit of surgery. And then the general payer mix. And these ranges are pretty big, so it's interesting. I'm not sure, how helpful it is to look at it, but I think it's a nice wake-up call for trying to figure that out. And then these were their identified technical assistance needs. that we asked them about, and it really helped us sort of take a look at what our expertise was, what could be offered by our contractor, and what we might want to bring somebody else in on. And some of these are very much related to the CDC funding, which had some specific requirements about asking about meaningful use and HIE and what kind of EMR you're using. And so the CDC side of the funding was a lot more, I think, prescriptive in what they wanted to know, but it was a great basis for asking some of our questions. So these are the 4 technical assistance webinars that we offered in the first year, and they're recorded and available to our RHCs or anybody's RHCs, frankly, at any time. And so they can be used as a continuing resource. And in the first one, the introduction seems kind of silly for rural health clinics, but a lot of them have new staff, and so they wanted to have an existing tool that they could use over and over again so that they had new staff come on so that they could get an introduction to the rural health clinic model. And then this is under the collection, the second part of what we want to do, which was collect on hypertension data. So this was, anybody that was willing to share it with us. This didn't mean they were committing to the Learning Collaborative project. It just meant that they were going to be submitting their data. So we have quite a few folks who are working with other health systems that were already collecting hypertension data for their projects. So they were really willing to help and to share so that we could have a better benchmarking across the board. And we already had an accountable care project going by one of our team members, and so this just fed into an existing portal, which is really, really helpful for getting them up. And really one of the goals of this project was also for those people who don't collect data to teach them how to do that and to give them some experience in doing that and helping them along the way. So I think that was really valuable for some folks as well. So you may not get a lot of usable data the first few times out, but they're really getting that, they're building that skill set, and they'll eventually be able to get data that's useful for both you as a project and for themselves for their clinical environment. So these are the Action Learning Collaborative. So this is where the sort of literally the rubber met the road with our sub-team going out and physically going to these rural health clinics that had committed to the project. And so these are some of the objectives that we were looking for, and so sort of overall guidance for how we wanted it to be delivered. And then the contractors and the project team itself figured out exactly what format that would take moving forward. And I just want to highlight the last bullet point refers to a resource that I'm also going to share with you later. We were lucky enough to have Dr. Fadrizi had developed this with the American Heart Association, and so it was ready to come off the shelf as a curriculum and be used in a clinical environment. And so that was a really wonderful thing to get us kind of moving faster and using it as a guide. So this is the basic learning collaborative process, and so it took these different stages, and I'm going to go through each of these very briefly just because I'm not sure how much time it'll take and the level of interest, but we can go back and talk about any of it. I did not run, as an aside, I did not run the learning collaborative, so as far as the actual on-the-ground stuff that happened, I'm not as well-versed in that, but if you had questions, I definitely can share that with you. But we'll, along through these slides, you'll see some of the tools and things that they used and the approaches they used, like the Plan, Do, Study, Act, and so forth.
Right down to the other end of the building. You're welcome.
So this is basically the timeline that we laid out, and we did this. Our chronic disease folks met directly with the contractor and laid this timeline out and really worked collaboratively to decide, how could we meet the goals of our funders and the contracts, but also what could we do to set ourselves up for success. So this is an overview of everything that happened in the course of the work with the Learning Collaborative. So part of the pre-work was this building relationships and shared knowledge. And so they worked on the idea of the 5 Ps and then talking about this global aim. And so the global aim for this is that they want to start establishing a baseline. I mean, these practices that participated were all very, very new to this idea of managing, using their EMR in a way that they could manage their patients and really hone in on a quality improvement goal, and then actually implement some clinical process change and some patient encounter change to actually make a difference. So a lot of it, this project was very much about the teaching and learning and the experiential aspect of the project. And then this is the global aim for all of them. And then, so in order to establish a baseline, we had to teach them how to collect all of that, and then that they were going to be using it with the achievement of 85% of their patients' population's blood pressure is in control for 3 months. And so there was a survey used that they used for engaging providers and the staff. And so they found, these are the things that we found out, is that most of them did these 3 things and fewer of them did these other things. And so it gave us some, for the side with the follow-up patients, the nurse clinic, and particularly the printed educational materials, I think it was a real opportunity that was identified for things that we could help assist them with. So they all did this, their own 5 Ps assessment with their rural health clinic name, and they went through and they stated their purpose and their people and all the fun stuff that goes with that, and then they identified their own opportunity for improvement that was at that point very specific to their RHC. So where, you know, they could look at themselves in comparison to their other peers and assess where there were opportunities for improvement that were specific to their RHC, and then use the materials from our team to support those opportunities. And so there were in-person learning sessions and a lot of coaching, a huge amount of coaching in a good way. They were very, very active and engaged. So we did this in-person meeting with a kickoff, and then there was the problem identification that was part of it, and you know, there was this sort of exchange of information of things that our team asked for that then the RHC teams would provide back, and then that helped feed into the in-person meeting so that the time was really valuable and it was used in the appropriate way. So they presented to each other, which I think is a really nice format. It's a very collaborative format. It's a very safe format for sharing. And then they talked about evidence and using an evidence base to inform their change ideas. So there's a global aim again, and then these are the 10 change ideas, and they're going to come into play with that resource. So this is the 10 steps for improving blood pressure control in New Hampshire. It's New Hampshire because it was created here by the folks that are listed on this book and some other people who are part of it, but I'm sure it works in other states. I don't think it's New Hampshire specific in any way, but and there's the information for a free download of that resource. And then this just talks, it's a little bit of a different way of looking at it and sort of the sphere of influence so that people can really assess where to spend their limited resources. This is another tool that we used that was a specific assignment they could use to help sort of outline their quality improvement project, and then as a team understand that and then present that to our consultants and sub-teams so that they could really talk about what was reasonable and even just basic stuff, you know, like you think everybody agrees on what a measure is and it turns out that they don't. So that way they could really talk about meaningful measures. And then the coaching came into place, so they're doing their own work at their organizations, and then there are phone calls going on as well as ad hoc calls as needed with coaching to do a number of things that you see here on this slide. So, you know, the team needs were varied, and so the coaching was varied in response to that. And then, you know, they got a chance to talk about their challenges and opportunities. And then they mapped their current process of care and their flow chart, which I think is, you know, I've done that as part of our work here in public health, improving our quality improvement training and processes and culture. And it's really eye-opening sometimes when you map a process and you work as a group and you learn a lot about assumptions and a lot about opportunities. And then this is just some tips on how to help them get through. So you just keep reminding them of the aim, and then you make sure that we're providing the tools that they need in order to make those changes. And so the next few slides here are just some of the tools. So these are, as you can see, they're wallet cards in a number of different languages. And the creation of these was actually supported by our medical society. And so these were handed out and used as a resource with patients. And then there's this DASH eating plan, another educational material that can be provided to a patient as part of that visit. and that disease management. And then another one here that talks specifically about the factors that lead to heightened blood pressure. And then more tools that you can use for translating your data into visuals. More tools indeed. And so there was support around teaching them how to use the tools and teaching them how to put their data in, how to read their data, what's significant, and anything that might be a trouble sign for data that looks a little bit wonky and maybe we need to go back and look at some quality issues around the data. And then this is just, it's a really nice kind of poster, if you will, overview that we can put together and that the rural health clinics themselves can use and then put in their own data specific to just their RHC about what they did. And then it's a really nice way both for them to present to the other folks in their practice, but also in other environments they might be where they want to talk about their work and how they got there. And then the next step really in this project and this network, and specifically with the learning collaboratives, is the spread and sustainability. And so what we've done is we're going to continue to support the hypertension work, but not as intensely, and we'll continue to collect their data and keep it in our dashboard. But we're going to be moving on to diabetes next. And so that is where we are now, is we are in, if you looked at this and changed the from 2015 on the left side and or 2016 and then put 2017 over here, this is basically where we are right now. The chronic disease program folks here are working very closely with the sub-team to, unfortunately we don't have a nice curriculum already for diabetes the way we did with hypertension, but they're working on that and they're going to be rolling that out. But they've already started to recruit rural health clinics. And what we found is not only are the current rural health clinics who are participating in the Action Learning Collaborative, but there are additional ones who are interested in being part of that project. And so what we try and do with the TA network is we just keep extending that TA back out to all of the rural health clinics, whether they've shown an interest before or not, because you just never know when you're going to hit that key moment in time and it's going to click for them. So I would say, just to wrap up, the key elements, what we did is when we had, when they agreed to participate in anything sort of beyond the TA level and the webinar level, we had an MOU and it had really clearly defined roles and really clear set expectations, and we really tried to live up to those expectations so that the rural health clinics knew exactly what they were getting into. We have an active listserv, which is great, that we use for not only letting folks know about the formal TA provided, but also other things that are offered. For example, when my office offered grant writing stipends to No Source Grant Writing Institute, I put that on a listserv and immediately got responses. If we have rural-focused or what we consider to be relevant to rural health clinic conferences or educational opportunities, we put those out on the listserv as well. And it's just, the listserv is nice because it's interactive, and so we're always keeping up with, like, if there's a practice manager change or an administrative change or a staff change, they let us know. And so we know that, most of the time at least, that we're getting that key core group of people who are really interested in getting the message, which is nice. We did the incentives, which took the form of gift cards that were given to the practice. And then the method of sort of delivering was the combination of the in-person visits and the frequent follow-up with telephone. So some of those were around formal projects like the assessment or webinars, and some of that was just, individual questions or issues. There's always something coming up, I think, in rural health clinics, and even if we don't have the answer, it's so nice to have our contractors who are incredibly well-versed and have a lot of expertise. And if they don't know the answer, they usually know the person who has the answer. So we're able to get back to folks and eventually get them the answers that they need. So I think I'm going to wrap up now, and we'll sit on this little questions page, and then you guys can just fire away, and hopefully we can answer your questions. So I see one question up. It says, any chance of expanding this chronic disease self-management? And I don't, I don't know if I've already answered that by saying that we're moving on to diabetes from here, or if the person who's asking that question means expanding it to other provider types. So I don't know that I can fully answer that without a little bit more information.
Have a good day. Thanks, you too.
Does whoever asked that question want to share any more details? They're still on the line? Oh, never mind. Gotcha.
Alisa, this is Marisa. Hi, everyone. I work on 1305. I'm wondering if the question relates to the chronic disease self-management program that was highlighted in one of the slides. And through our 1305 cooperative agreement, we're actually not able to support CDSMP, so that's something that they would be doing on their own. I think that's what that might have been referring to.
Thank you, Marisa. Once again, highlighting how important it is to have partners.
Yep, we just got a couple additional clarifying comments. First, expanding beyond diabetes for clarification, and then following actually through the D4S4 part of the 1304 grant. So it sounds like we've closed the loop on that.
Great.
So, anyone else have any other questions? Now's a great time to take yourself off of mute and feel free to pose any questions to Marcella or Alisa.
Can you hear me?
Yep, we can hear you.
Oh, I'm sorry. Thank you. This is Carol Eisinger with NOSOR. I'd really thank ASTHO for putting this webinar together and for sharing that good work of that collaboration. I want to ask both of you. You had said, you made a comment that the networks were really important in launching that work, the regional public health networks. And I'm curious what kind of, if you could talk a little bit about how those are formed, and maybe I missed that, but I'm very curious about how those start. I think they're just a great example of that public and rural health collaboration. Maybe you could talk about funding a little bit and what lessons you learned from starting those.
So essentially, our public health networks were created, I'm going to say 12, 13, 14 years ago, and the essential issue that helped them come forward is that in the state of New Hampshire, as small as it is, we have two cities, Nashua and Manchester, our largest cities, that have local health departments, full, comprehensive local health departments. And so they are very small geographically down in the very southern part of the state. The rest of our state has no public health infrastructure at all. So we're a very centralized state. And the original funding for these public health networks, and at that time there were probably 20 of them. Every community wanted to be its own little network. And the reason that the state began to fund them with federal dollars primarily, it was for emergency preparedness. After the floodgates opened after 2001, the emergency preparedness funds started to come out. We created these networks so we would be able to work more directly in a more organized fashion with the police departments, the fire departments, the volunteers, and started to develop these emergency networks. So as time has gone by, we now are down to 13, and we use these in many different ways. We still use our emergency preparedness funds and move funding out through the state to these regions. We have also added other elements. For example, the immunization program wanted to start school clinics. This is after 2009. We wanted to start school immunization clinics. So we have funneled funds through those same systems to have the volunteers and the staff, limited staff, in those networks also do essentially what are drills by having school flu clinics. And we also have pushed funding out for climate change adaptation funding, and I think some of our chronic disease, and maybe some of those folks could step up. So we have other public health units essentially have begun to move money out into the public health networks in that fashion. The big change came, I think, about 2 years ago when our Substance Misuse Bureau, which is in a different part of our major umbrella system, they aligned their alcohol and substance misuse funding. They aligned their networks to our networks, and so now that funding is all bundled, and now we have increased our staff out there, increased the funding greatly at that point. And then 2 years ago, we also sent out funds for them all to do a needs assessment, a community health, essentially an improvement plan, a CHIP plan, in each one of the networks. So they were able to create these community, large public health network community plans, and they are working on those. They are aligned to our state health improvement plan. So all of our regions are now working on their own improvement plan and developing, hopefully, a greater sense of stakeholders and collaboration. We also have, the most recent iteration is we have an 1115 waiver in our state, and we were able to use essentially that same framework to set up our integrated delivery network system that was a part of that whole process. So they continue to be very much a part of this integration of behavioral and physical health care out in our communities. So the networks have become very important for us because it gives us all a framework in which to work at the local level.
And then I just wanted to add something from a purely practical sense. For data, it's been incredibly helpful for them to be organized, because what that means is that where possible, the data that we put out as a public health division is available by public health region. And so what that means is that our constituents can use, we have an external facing system called Wisdom, and it has all the data that we have and some pre-established dashboards that match those SHIP goals that Marcella, the SHIP areas of priority that Marcella mentioned in the beginning of our presentation. And so our folks can go up there and they can pull their data, and what they can do now, because we have classified them as rural or non, is they can pull their rural data in comparison to non-rural and the state, and instead of having to make a separate data request to our data team and waiting 6 weeks in order to get that. And I used to myself, in order to do my rural data report for my funders and to assess our priority areas, was I had to pay an outside consultant to request the data from our group, bring it into their system, and sort it into our own unique New Hampshire definition. And I was able to give that up and redirect that energy and resources to other projects, because now we can use this system. And so the more people in public health and the more people who in the department and eventually the state use this same classification, the more we're speaking the same language when we talk about rural New Hampshire, as opposed to the 42 definitions of rural on a federal level.
Well, you are both tenacious women. Thank you for that.
Very tenacious.
Any other questions from the group, from the audience? I'll give you a second to get off mute if you have a question. Otherwise, I have one sort of quick question for you both around sort of, if you were to sort of synthesize this down into, just your top couple of takeaways for other states trying to implement an intervention like this, what would you sort of recommend to those other states doing this work?
I would say that I would recommend that that if you think your project is too small to be meaningful, change that thinking, because I don't think that's the case at all. The really wonderful thing about rural is that innovation, it can be done fairly easily, because there's so few people that you can really come together, and they're just they're committed and passionate in a way that I've never seen in any other setting. So even if it's small, if it's valuable, they will latch onto it and they will appreciate it. And you will start to develop networks and relationships with people, and they will start to see your value as a program, and then you can start adding more and more things on as you're able to do so. I would also look for state resources that you have that are already have been created, ideally an evidence-based, but if not that, a best practice, and then, assess whether or not they're appropriate for rural, or maybe it's just the way the delivery method is. But I would say that, don't be hampered by not being able to pull off something really big, but at the same time, I would definitely, assess your own capacity, and if you need to get some outside expertise and contract that, I would do that as well, because what you really want is, even if it's a little project, you want it to be a roaring success so that you can start moving on to other projects.
Great, thanks. So do we have any other questions from the group? Want to sort of offer up one more opportunity for that from folks? Otherwise, we can go ahead and wrap up here. Thank you all, again, so much for your time this afternoon. We really appreciate it, and especially Marcella and Alisa, thank you so much for taking the time to share a little bit of information about your work and your project there in New Hampshire. We're going to go ahead and put these slides online, so they will be distributed. Our contact information is up there, so if anyone has any further questions that sort of come to mind after we wrap here, feel free to reach out to us and get in touch. So with that, we'll let you all go. Thank you all so much.
Thank you.
Thank you.